A very good morning to all. I'm Dr. Rahul, a neonatal consultant at Ikra Hospital, Calicut. So, we have so far discussed here about the antenatal management, the delivery, the transport, and the postnatal management of preterm babies. Now, I'll briefly go through the essential preterm care in the neonatal intensive care unit. So, as just an overview of the classification of preterm babies, so that is born less than 37 weeks of completed gestation. So we have divided them into late, moderate, very, and extremely preterm. Extremely preterm, as you all know, it is born less than 28 weeks of completed gestation. Very preterm, it is 28 to 31 plus 6 weeks of completed gestation. Moderate preterm is 32 to 33 plus 6 weeks of gestation. And the late preterm is 34 to 36 plus 6 weeks of completed gestation. So the more premature the baby, the more the complication they develop. Now, when the baby gets admitted to an ICU, we have to monitor them properly. So things to look for when we are doing the rounds is always starts with the vitals. So temperature, heart rate, respiration, blood pressure, saturation. Then the activity and behavior, which tells you a lot about the baby. Then about the color of the baby, whether it's pink or is the baby dusky, or the baby is jaundiced or is the baby cyanosed. Then tissue perfusion is another entity which we need to look into, which can be assessed from the color, capillary refill time of the upper chest, then warm and pink extremities, urine output, blood pressure, and absence of any metabolic acidosis if there is an ABG available. Then you need to look for the tolerance of feeds, whether the baby is having vomiting or any gastric residuals, and abdominal girth need to be monitored. Then the amount of fluids given, input output charting, electrolytes, and the blood sugar needs to be seen. Also, we need to carefully look for the complications of prematurity in all babies on every day. That includes RDS, apnea of prematurity, NEC, intraventricular hemorrhage, PDA, sepsis, etc. And daily weight gain monitoring is also important. It helps in planning the fluids as well as the feeds, and how to increment all these things can be made using this weight monitoring, urine output, electrolytes, etc. And weight gain velocity also needs to be plotted in the growth chart so that we can assess the nutritional status of the baby. So all this monitoring, the frequency varies. That is, it depends on the gestational maturity as well as the clinical status of the baby. So now coming to the temperature regulation, it has already been discussed in detail in the previous session. So these preterm babies are prone for a poor temperature control. That is, they can go for either hyperthermia or hypothermia. So this can be due to immature heat regulatory center or impaired heat production, or there can be an increased heat loss due to various mechanisms. So our aim is to achieve the thermoneutral environment, which is optimum to maintain less oxygen consumption. So the normal temperature range is around 36.5 to 37.4 degrees Celsius. So once the baby goes below 36.5, that baby is in cold stress, and when it goes beyond 36 degrees, so less than 36 degrees Celsius, baby is set away hypothermic. Now coming to the respiratory system, two of the most common things that we see in preterm babies is respiratory distress syndrome as well as apnea of prematurity. So these babies um, what we use is, when there is respiratory distress syndrome, what we use is the CPAP. The CPAP is indicated for respiratory distress as well as apnea of prematurity and in post-extubation in preterm babies. CPAP, what the CPAP does is it provides a constant air pressure both during inspiration and expiration, and it keeps the alveoli open so as to reduce the work of breathing. Also, and it keeps the airway splintered so that functional residual capacity also improves. So these things in effect leads to better breathing as well as better gas exchange and less lung injury compared to a ventilator. So few of the evidences and recommendations regarding CPAP. The CPAP should be used early in the course of RDS so that the need for mechanical ventilation can be averted. And when you apply CPAP in respiratory distress syndrome, it reduces the respiratory failure as well as the mortality. And when the baby is on CPAP, always try to, when you're giving surfactant, always do insure technique and then put the baby back on CPAP. Insure is intubate, surfactant, and extubate. The next question that we do ask is how early we need to give the CPAP to babies, whether we can give prophylactic or how can we give the CPAP in the delivery room. So there is no role for prophylactic CPAP, that is, without any symptoms of respiratory distress, you can't start CPAP. But you need to start CPAP at the earliest when there is signs of respiratory distress in neonates at the risk of respiratory distress syndrome. So the criteria most commonly used is the Downey score. If the score is more than 4 or more, that is an indication to start the baby on CPAP. So this one just tells the Downey scoring. That is, there are 5 components: respiratory rate, cyanosis, retractions, grunting, and air entry. And in the delivery room, always you can start CPAP if you have the facility. That is, if you have a TPS resuscitator, or if you have a transport CPAP, you can always start. Thereby, you can prevent worsening of the condition. Now, weaning again, it varies from unit to unit. So we have to wean once the baby is stable on CPAP. Start weaning the FiO2 first and then come down on the PEEP. And once the baby is comfortable and attained a normal saturation with minimal retraction, you can take off the CPAP and see. The next thing is the surfactants and when to use the surfactant. So the surfactant, what does it do is it stabilizes the alveoli, reduces the surface tension, thereby improves the oxygenation and decreases the need for ventilatory support. And also the surfactant reduces the pulmonary leaks, air leaks, and improving the survival. Surfactant must be considered in all preterm infants with a strong clinical suspicion of RDS, those who are on CPAP and having increased oxygen requirement. So this surfactant is very effective in the treatment of respiratory distress syndrome in preterm infants more than 28 weeks of gestation. And in less than 28 weeks, it should be individual based because it has to be discussed with the family about the cause, the prognosis, because they'll have a long duration of stay and the chance of complication is high. So you need to consider all these factors before giving surfactant in those babies. So giving surfactant, there are 3 methods, that is prophylactic, early rescue, as well as the late rescue. Prophylactic surfactant administration is given within initial 50 to 30 minutes of life, but after stabilizing and resuscitating the baby properly. It is not recommended routinely. The recommended one is early rescue, where preterms with respiratory distress suggestive of RDS administer the surfactant within the initial 2 hours of life. So thereby you can uh, prevent the worsening of respiratory distress syndrome as well as going into mechanical ventilation. Then comes the late rescue, where you give the surfactant after 2 hours. It can be uh, whenever you give surfactant, if it is late, even though uh, if it is more than 2 hours, you need to give at the earliest possible when you diagnose RDS in these babies. So some of the recommendations regarding surfactant that ensure is the approach recommended for surfactant administration. And when you are decided on surfactant administration, you should start the baby on CPAP because that facilitates the alveolar recruitment. And extreme preterms, again less than 28 weeks, initiate CPAP early and with selective early rescue surfactant. The surfactant can be administered in level 2 and 3 units with appropriate trained personnel, equipment, and monitoring facilities, but not in a level 1 unit without these facilities. Now, coming to the cardiovascular system, mm, two of the common things that we see in routine are the hypotension and PDA. So, hypotension in preterm babies can be due to uh, many factors together. That is, hypovolemia can be there because of the prematurity, water loss, etc. Then cardiac dysfunction can be due to prematurity with along with vasodilation. It is again the tone of the vessels are reduced, and sometimes there can be, if there is associated sepsis, it can cause vasodilation. So that blood pressure needs to be monitored. And the next thing is PDA, that is patent ductus arteriosus. In these babies, there can be wide pulse pressure, bounding pulse, and sometimes it can result even in congestive cardiac failure. You can hear a systolic murmur in the upper chest. Coming to the gastrointestinal and nutritional aspects, it will be discussed in detail in the coming sessions. So, a couple of points regarding the preterms. They are they won't be able to suck and swallow properly at lower gestational age, and this coordination of suck and swallow comes around 32 to 34 weeks, and due to their intestinal dysmotility, feed intolerance is a frequent finding in them, and also they are prone for the extreme problem, that is necrotizing enterocolitis. Then this is a rough guideline for like when to start feeds and fluids. This is have taken from the AIMS guideline. So less than 30 weeks of gestation, always mostly you'll start with the intravenous fluids and total parenteral nutrition. 30 to 34 weeks, it is mostly will be cabbage feeds, and more than 34 weeks, obviously, when the baby is having a good coordination of suck and swallow, you can try for breastfeeding, and if it's unsatisfactory, you can start him on spoon feeds. Then the renal system, the kidneys are immature again, so they'll have a low GFR, and the kidneys won't be able to handle water, solutes, and acid loads. So these things needs to be monitored in these babies in the initial days. And regarding the drugs, the dosages will be different from the term babies, the dosages as well as the duration of giving. So that also needs to be seen properly in these babies. Now coming to oxygen therapy. So this is one of the most debated area, oxygenation. It is essential for the normal function of the body, but oxygen in excess is dangerous. Both this hypoxia as well as the hyperoxia are harmful to preterm babies, and what we can do is to monitor the saturation with pulse oximetry, and monitoring is essential. Monitoring and keeping the oxygen targets are essential to prevent the harmful effects, especially to the brain, the lungs, and the retina, etc. So, for oxygen saturation targets, there are no firm evidence, but there are literature which says um, oxygen targets should not be more than 95%. Optimum oxygen saturation level should be around 90 to 95 in most of these babies, and in preterms less than 32 weeks, some guidelines suggest it as 88 to 92%. So keeping alarms at this set limit is essential whenever the baby is on oxygen. Then the next thing is ophthalmologic evaluation for retinopathy of prematurity. Nowadays, it is becoming one of the leading preventable cause of childhood blindness in India because more and more preterms are surviving. So the chance of developing retinopathy of prematurity is increasing. So the question is whom to screen. So as per the NNF guidelines, all preterm neonates who are born less than 34 weeks of gestation and or less than 1.75 kilograms of birth weight needs to be screened, and babies with 34 to 37 weeks of gestation or 1.75 to 2 kilograms weight, if they have associated risk factors, you can consider screening those babies as well. And the first examination usually performed within first 4 weeks or around 4 weeks of life with the infants born more than 28 weeks of gestation and less than 28 weeks or less than 1.2 kilos, they should be screened a bit early, that is around 2 to 3 weeks of age, to enable early identification of RDS. And this is one table which was circulating in the WhatsApp. This is some of the important medico-legal cases in relation to ROPs in India, and you can see the most of these cases the doctors are on one side, so we should not take any chance. These things comes late when the baby comes with blindness. Then a couple of the surgical conditions which you need to be aware is, one is an umbilical hernia, which obviously you can see. The other thing which you may miss is the inguinal hernia because baby will be always in pampers. So always it is better to do a discharge examination to make sure that these things are not there for these babies. Then coming to the investigation part, blood investigations are there which you can do, includes complete blood count, CRP, blood culture, electrolytes, calcium, and serum bilirubin. Chest X-ray can be done for preterm babies with respiratory distress. The findings you can see in respiratory distress syndrome. It includes a low lung volume with ground glass appearance, air bronchograms, and reticulogranular pattern. And in extreme cases, you may see a white outline. Echo can be done to look for congenital heart disease and especially PDA. Then thyroid screening needs to be done. It can be done from the cord blood or can be done after 48 to 72 hours. And it is always better to do a rescreen after 2 weeks because there can be a delayed rise of TSH. So in such cases, you may miss cases of congenital hypothyroidism if you don't do screening after uh, 2 weeks. Then again, cranial ultrasound is another investigations. It should be done in preterm babies. Different guidelines are there. So you need to consider scans in less than 32 weeks and less than 1.2, 1.5 kilogram babies. So it can be done in the second week of life and then can repeat one after around 36 to 40 weeks of life. Then the next thing is the developmental supportive care. So this is the one I think which most of us are ignoring in an ICU, but the baby needs the most. So developmental supportive care, here the babies, that fragile preterm babies who are comfortable inside the maternal womb, is suddenly pulled out and placed in an environment so different from their safe and secure world of the womb. They do enjoy a lot of leisure inside the womb that includes a cushioned and comfortable aquatic abode that where they float Then they got the thermal comfort, then which is the maternal temperature, and zero insensible water loss because they are in the fluid, shielded from light and sound, and they've got adequate oxygenation, then optimal excretion of waste products through placenta, then the parental nutrition, asepsis, etc. So baby is coming out from such an environment, and what we need to do is we need to make sure that we should be providing care. At least we can't reach the complete womb atmosphere environment, but we need to try to make it to a level such that the baby is comfortable outside as well. The neonatal intensive care unit is their first home, so we need to give the developmental supportive care. So, a developmental supportive care is a structured care environment to support, encourage, and guide the development of a preterm or critically ill baby. So, the core principles include it stimulates the senses that develop early, that is, the touch, smell, and taste, and to protect the senses that develop later in their life, that is, vision and hearing. So some of the few points are that around 100,000 of neurons are released daily from the germinal matrix, uh, around from 30 to 40 weeks of life, intrauterine life. They migrate to their destinations. They either stay there or undergo apoptosis, which are natural processes in development. So any disruption in this is harmful to the baby. Developmental supportive care, there are five components, that is protected sleep, provision of a healing environment, family centered care, and activities of daily living, pain and stress management. So, the protected sleep includes nesting the baby, then kangaroo mother care, and the cluster care so that the baby won't be disturbed and other times. Then, activities of daily living like massaging, feeding, and skincare and diaper changing should be done, and the parents should be involved in these activities as well. Then the next thing is the healing environment. That is, we should not disturb the baby. The light should be dim, and we should try to minimize the sounds in the NICU. That includes the monitors, where we need to keep alarms properly and to switch off the alarms when in need. And uh, then comes the management of pain and stress. We should be gentle in their care. That is, should include non-nutritive sucking, swaddling, and they need to contain during their procedures. Also, need to try for the pharmacological as well as the non-pharmacological methods to prevent pain. Then the family should be included in the care of the babies, should be educating them, and also we should give emotional support to these parents during their initial critical periods. So, I've just briefly given an overview regarding the preterm care in NICU. Most of these things will be dealt in detail in the coming sessions. Thank you for your patient listening. Thank you.